So I'm going to give you a brief introduction to radiotherapy here. This is for the MSc Therapeutic Base of Cancer module. And in this, from this video, I'm not going to talk about tumour stage, that's in the lecture notes, but I'm going to talk about these 6 different radiotherapy modalities. We're going to look at why they are used for specific tumours, why they're not always used, why would we use proton beams for one particular situation and brachytherapy for another. So we're going to look at different sorts of radiation that can be used for radiotherapy. So we can either use electromagnetic radiation, which is basically just the extension of the light spectrum, so X-rays and gamma rays, typically used in external beam radiotherapy and to some extent brachytherapy. Or we can use subatomic particles, so alpha particles, beta particles and proton beams. Alpha particles are large, relatively large helium nuclei. Beta particles are electrons, primarily emitted from brachytherapy, which is implants of radioactive materials. And then proton beams are beams of protons which are fired externally, much in the same way as X and gamma ray, but these are beams of protons rather than photons. So the different sorts of radioactive particles or photons that we are interested in. Here I've just mentioned alpha particles, which is a helium nucleus, and these are generated as radioactive elements decay and then emit an alpha particle. These are highly damaging to DNA, but they have a very short range, so you have to get these radionuclides right next to the tumour cell to have any chance of them having any activity. Other radioactive elements will undergo beta decay, which is giving out a beta particle, so that's loss of an electron or a positron. These have short range activity and are less ionizing than alpha radiation, and given that they have this short range, these tend to be used for brachytherapy, where radioactive implants are implanted maybe every centimetre throughout a tumour, and then they emit electrons which have these high energy electrons will cause damage within the tumour specifically. So gamma emission is where the radioactive particles can give out a photon of very high energy electromagnetic radiation, which, as I mentioned, is just an extension of the spectrum of light. For most radiotherapy, we don't use radioactive decay of radioactive elements that give out gamma. We use a linear accelerator which generates X-rays at a very specific wavelength. But in other applications, such as stereotactic radiosurgery, we do actually have we rely upon radioactive decay of cobalt-60 that gives out gamma, and then we focus multiple cobalt-60 sources to a specific point within the tumour. So sometimes we use gamma emission from radioactive decay, sometimes we have a machine which generates gamma radiation at a specific energy. So X-rays and gamma rays travel much in the same way as light. They travel at the speed of light, they travel in straight directions, and they have a energy, and that energy that we can describe to them is electron volts. And the therapeutic X-rays are in the mega electron volt range. Diagnostic X-rays are much less penetrating and less high energy, and those are in the kilo electron volts, as opposed to light, which is much lower energy. So if we have ionizing radiation, this is where either a photon or radioactive particle interacts with an atom and ionizes that atom, so effectively removes electrons from the atom, so it becomes charged, and then you get a highly reactive and destructive electron given off. So this is ionizing radiation, whereas at lower energies we get excitation of electrons, and this is the sort of thing you get going on with fluorescent molecules. You can excite them with a photon of low energy light, you can excite an electron to a higher energy state, it can drop back down and emit light. So this is just excitation. What we want to do in radiotherapy is generate ionization, and one of the main things that gets ionized within the cells are water molecules, where we can effectively split water molecules into hydrogen radicals or OH radicals, and they can be highly destructive and damage DNA. Or we can have radioactive photons or radioactive particles hitting DNA directly and causing direct DNA breaks. So this is shown here. We've got some DNA here that's received direct double-strand break, so that's a radioactive particle passing through the DNA and causing a double-strand break, or just a single-strand break. If this is unrepaired, that will lead to a double-strand break and the replication fork would collapse. Alternatively, a photon can come in and interact with a water molecule, split that water molecule into a hydroxyl radical, or knock off an electron that can react directly with DNA and damage the DNA. And this is what we could call indirect DNA damage, because the photon or the radioactive particle is hitting something else which is then reacting with DNA to damage that DNA. So this is shown in more detail here. We've got an X-ray photon hitting a water molecule that can be split into an ion pair, where we firstly lose an electron. We'll worry about that in a minute, and then we'll get a hydrogen ion and the hydroxyl radical, and both of these can be highly reactive and react with other things. If these occur in close proximity to DNA, then you can get DNA damage from these. This electron that is kicked off can then react with another water molecule, creating a hydroxyl ion and a hydrogen radical, and again both of these can be both are highly reactive, and if you can generate them in close proximity of DNA, you can generate DNA damage. So when we're dealing with DNA damage, we're interested in the absorbed dose, which is how much energy is actually received by the patient. Now, a lot of the energy will pass through the patient, some of it is absorbed, and we can express this in grays. So when we see treatment schedules, we'll often see grays of radioactivity, which is the absorbed dose of radioactivity. When we are dealing with this, we have to remember that alphas are much more ionizing than betas or gammas, and the equivalent dose of alpha is 20 times higher than beta or gamma. And this is because alphas are 20 times more damaging per joule of energy than beta or gamma. So when we're dealing with grades of radiation in the therapy, we're interested in the therapeutic ratio, which is ratio of the probability of the tumour being controlled by the radiation compared with probability of a serious late effect tissue damage. So you can't just give unlimited amounts of radiation without causing some severe damage. So if we want a 97% chance of controlling that tumour effectively, we could give this dose, but that would have a very high chance of having some normal tissue complication. Whereas if you went to somewhere like here, you would have an 80% chance of controlling that tumour with just a 20% chance of causing some long-term problems as a result of the radiation. Now, the ideal situation is to separate these two lines as much as possible, and there are various things that can be done to do that. And just irradiating a tumour with a straight beam of photons would bring these two lines closer together, whereas if you do something like stereotactic radiotherapy or intensity modulated, or some sort of system that allows you to direct the radiation directly at the tumour but spare the normal tissues, then you can separate these lines much more. So firstly, we'll look at radionuclide therapy. This is where we are injecting a radioactive element into the patient and then allowing that to decay within the patient to damage the tissues. And with iodine, that's used to treat thyroid tumours. Thyroid tissue naturally absorbs iodine, so if you inject someone with iodine, it will mostly accumulate within the thyroid very, very quickly, and if that's where the tumour is, then those cells are going to die. So here we can see a scan of a patient who's been injected with radioactive iodine, and you can see that we've got a very strong imaging signal of the iodine in the thyroid, and that's at a low intensity image. You can see a faint image here. If you then do that at a high sensitivity image, yes, this is really intense here, but what it's highlighting is that the patient has got cells which are absorbing or uptaking iodine disseminated throughout the body, including the brain. So this indicates that this patient has got metastatic thyroid cancer disseminated throughout the body. Now, as long as the thyroid cells continue to take up iodine, then even these cells in the brain should be killed by that radioactive iodine. The problem is metastatic cells also sometimes de-differentiate to become no longer thyroid-like, and as soon as they stop taking the iodine up into the cell, then you start to generate resistant tumours. They don't die in response to the radioactive iodine because they are not taking up the iodine. So also included in radionuclide therapy is radium. So radium-223 is a bone-seeking radiopharmaceutical. Many different radium isotopes exist that emit by ejection of a helium nucleus. The one that is used therapeutically is 223, which is used because it has a suitable half-life. It's used for prostate cancer bone metastasis because radium accumulates where calcium would naturally be deposited, where there's new bone formation going on. Since prostate cancer cells drive new bone formation as well as growing within the bone marrow cavity, that would create an environment where radium would accumulate. That will accumulate right next to where the tumours are, emit alpha particles, and those alpha particles will be active over a very short distance but are very damaging. This trial is also going on for osteosarcoma. Osteosarcoma is a osteoblast-derived bone cancer where you get aberrant osteoblast activity. Osteoblasts make bone, so therefore radium will accumulate around these tumours. So we can also tag radioactive metals to antibodies. In this case, yttrium-90 is being linked to this anti-CD20 monoclonal antibody. CD20 is present on B cells, so this can be used for CD20 positive non-Hodgkin's lymphoma. We can inject this antibody. It's linked to a radioactive element that will bind to CD20 positive B cells, including the cancer cells, and should cause, by beta particle emission, local death of those cells. We can also use a gamma ray emitting version which has got indium on there instead, and that is more used for diagnostic imaging of the extent of non-Hodgkin's lymphoma to see how far disseminated the disease is. So brachytherapy is where we implant radioactive seeds impregnated within metal into the patients, and these typically undergo majority beta emission and to some extent gamma emission. Iodine-125 is used in these radioactive pellets or seeds, which are in this case implanted into the prostate. So this patient's got prostate cancer and dozens of radioactive seeds spaced about every centimetre or so apart. We know that the beta emission from these will travel and be ionising for up to a centimetre or two. So as long as you've got a seed every couple of centimetres and no gaps in between, you've got a good chance of ablating that entire prostate without having to do surgery. We can also use cesium-131. That has a much shorter half-life, so you deliver the dose in a very short period of time with this one. So other forms of radioactive implant would include plaque brachytherapy. In this case, ruthenium plaque, which undergoes beta emission with a half-life of 377 days. So we tend to use this for optic tumours, particularly for ocular melanoma, also called uveal melanoma. So when these plaques are brand new, they're very hot, very radioactive, and over time they lose their radioactivity. What happens with these is they are used on one patient, implanted for 2 to 7 days, removed, and then used sequentially on other patients. The time that the implants are placed onto the eye varies depending on how deep the tumour is. If you've got a very deep tumour, you'll leave it on for longer, but equally you don't want to damage the sclera too much. And we can put the implant on there, so there's the rim, and then we can calculate the dose. So we know that in this case there'll be 85 grays up until that apex of the this sort of region here. So we can stick this implant on there and calculate how much dose there will be, and if the tumour extends beyond there, you leave it on for longer. So different radionuclides have different emissions. Alpha has a very short range, so you have to get that right next to the cell. So this is where we tag it to antibodies which stick directly to the tumour cells, or with radium we inject it into the patient, and that will accumulate around tumours in bone. We use beta emission in plaques and radioactive implants. They have a maximum range, depending on the energy of the electrons emitted, of 0.8 to 2.4 centimetres throughout soft tissue. So if you've got radioactive implants in the prostate, you're going to space them, centimetre apart, that sort of range, maybe even closer, and you can then create a matrix to calculate how they should be implanted to give even coverage of the entire prostate. So we're now moving on to external beam radiotherapy, where we are firing high energy X-rays at the patient's tumour via a linear accelerator. So this is using information from a CT scan or other imaging modality to identify the exact shape of the tumour, and then we can fire photons in a beam that matches that shape of the tumour, and then rotate the source of the photons to match the shape of the tumour from a different angle. And what that does is it limits the amount of radiation received by any of the normal tissues, and we fire the photons from multiple angles at the tumour, but keep changing the shape of the beam so that it always ablates the tumour and irradiates minimal amounts of normal tissue. And this is all in the high energy X-ray region. And this system is used for the majority of external beam radiation. This can be taken a step further by doing gamma knife and stereotactic radiosurgery. In this situation, typically used on brain tumours, we have cobalt-60 sources which are all emitting gamma. All of these cobalt sources are directed in such a way that they emit gamma that all focuses on a very fine point here. So the patient puts the head into this contraption, and then the gamma is focused just onto the tumour, and the rest of the brain sort of takes an equal burden of the gammas that are going in. So no one region of the brain receives a really high dose of radiation apart from the tumour. And these modern gamma knife and cyber knife robotic radiosurgery systems have an accuracy to about 1 millimetre. Okay, so finally we're going to look at protons. So the previous one was looking at gamma, this is looking at proton beam therapy. Protons are fairly unique in that as they pass through tissue, they slow down and then suddenly interact with tissue at a certain speed or energy, whereas gamma rays tend to, majority of them, pass straight through. So with the linear accelerators, most of the radiation that is fired at the tumour passes straight through, and you have not so much exit wounds, but you have DNA damage where the gamma rays enter the body, and to some extent where they leave the body as well. With proton beam therapy, it's the entrance where it enters the body. Yeah, that does still cause some damage, but it doesn't. The protons don't leave the body, and this is all down to what's called the Bragg peak effect, where photons are fired at the patient. As they go through the patient, they slow down, lose energy, and when they hit a particular point, they suddenly interact and have a very ionizing effect, and then they don't go any further. Now this is really useful because if this is the depth of the tissue, let's say 30 millimeters, and there's something crucial like a spinal cord at 35 millimeters, we can irradiate the tumour but send virtually no radiation to the spinal cord. That sounds great in practice. The problem is there are very, very few systems available to do this. So if we compare external beam radiation with X-rays, we fire the X-rays at the tumour, they pass through the tumour, they ionize either in the tumour or within the normal tissues. We can repeat that from as many different directions as we can possibly do to have X-rays going through the tumour this way, that way, that way, and that way, and try to selectively kill the tumour. And that's the basis of external beam radiation using those linear accelerators. However, if there's a crucial structure just behind the tumour like the spinal cord, this is going to cause some problems. And this is where the proton beams come in, because we can tune them, we can fire them in at different energies. At different energies they have different depths at which they preferentially interact, and this is this Bragg peak effect. So at a certain energy they'll come in and interact with tissue mostly at just one depth but penetrate no further. So we can fire protons this way at the tumour, and we can have them so that they preferentially interact with tissue at whatever depth this is, and then repeat the procedure from this direction, but this region here, which is the spinal cord, is receiving virtually no radiation, and that's shown here. We can have healthy tissue, the protons come in through healthy tissue. Yes, they will interact to some extent with the healthy tissue. They will preferentially interact at a certain tissue depth, and what we can do is have very high energy protons which will interact at deeper tissue depths, and then repeat the procedure at lower energies and get this spread out Bragg peak effect from multiple sets of photons at multiple different energies, so that the tumour is this region here which has been irradiated. The healthy tissue has also been irradiated, we can't get around that, but the healthy tissue here is something non-important like skin, whereas the healthy tissue behind the tumour could be something rather crucial like the spinal cord. So this system is used for brain tumours where you really want to spare as much of the brain tissue as possible. So going back to the overview of the session, we've covered radionuclide injections, we've covered antibodies bound to radioactive elements, we've covered brachytherapy, which is radioactive elements within a implant, external beam radiation, which is using high energy X-rays fired at the patient. The problem with that is they pass through the body, they come out the other side, they can cause damage behind the tumour. The gamma knife and stereotactic radiosurgery can be very targeted specifically to the tumour and spare tissue sort of behind the tumour, so we focus in gamma rays at the tumour specifically and sparing the normal tissue as much as possible, and in using a different approach we can do the same thing with proton beams.